So with that, I will turn it over to Dr. Ruby Sahoo. Thank you so much for joining us again.
Thank you, Josh, and thanks everyone for joining me today. The topic of discussion will be update on operational considerations for COVID-19, specifically for hospital medicine. Many of us have been dealing with COVID-19 in different ways over the past few weeks, so this will hopefully bring some clarity on streamlining workflow and things to consider on the inpatient side. So the purpose of this talk will be for us to prepare for the surge. Many of us know that volume will increase with COVID-19 as it comes into our areas. Some parts of the country are already seeing a large volume increase at their facilities. I also want to talk about minimizing risk of exposure. So talking about facility considerations as well as workflow considerations, how best to communicate during this time, and also ways of devising discharge plans for COVID-19 patients. So the question is, why should we care? Why should we be adjusting staffing during COVID-19? This picture, many of you may have seen. This has been in a lot of media outlets, and this picture really hits home for me. This is a physician who has been quarantining himself from his young son, and that's his way of interacting with his son during this time. And coming from a dual physician household, my husband and I have been doing this ourselves with our son. And I know many of you on this call that are listening in are doing the same types of things. So with that, I want to talk about why this would be important. So the main thing that we want to look at when we're talking about how to adjust when the volume is low and then high is we want to protect our workforce by minimizing the number of providers that we're exposing to COVID-19. Essentially, if you don't have to be there, you should not be. And flexing the staffing in that way will certainly protect the workforce and allow us to minimize the exposure when it's not needed. We also want to increase the bandwidth for our physicians and APCs to assist when that census does increase. So many facilities, like I mentioned, are already seeing a volume increase. And for those that are not yet there, if your volume is low, it makes sense to keep people at home, rest up, so that you can help when the help is needed. And lastly, we want to allow physicians and APCs who would just rather be at home altogether or even decrease their shift length. So a lot of physicians and APCs would take that opportunity to go home early, be with their family. A lot of schools are closed, spend time with their kids rather than sitting in the hospital when there isn't much volume there to justify it. So we'll talk first about low volume before the surge. And so many of us are already seeing this. It's been described as the tsunami effect, when the tsunami is coming, but the tide is extremely low as the water is pulled out to sea. And that's what a lot of us are seeing. We know that that tidal wave of volume increase is going to be coming, so now is the time to prepare for that. So I'd say to first ask for volunteers, who priority to be given for the providers who are scheduled for the highest number of hours and potentially needing a break, and also for providers with personal needs that would appreciate being home. So those physicians and APCs that have, let's say, kids at home, parents that they're taking care of, immunocompromised loved ones, whoever it is, they're just needing a break. Let them go home if they don't need to be there. And even changing around the shift model. So there's been a lot of creative staffing ideas, including just a round and go model in lieu of the traditional rounding versus admitter shift model. Essentially, if you don't have to be there for the entire duration of the shift, if it can be handled with cross-cover admissions, codes, whatever, with that current volume, it's probably not needed for every person to be there when the census is that low. And considering even consolidating units and coverage. So, for example, if normally there's one physician designated for the second floor and another physician designated for the third floor, if the volume is low enough, potentially that third floor physician can go home after he or she is done rounding, and the second floor physician would cross cover for both units. Or even if the volume is really low, having even just the second floor physician cover both units and giving the third floor physician a day off. And certainly they can alternate to provide coverage or whatever is needed. Next, I'll talk about high volume due to COVID-19. As I mentioned, some facilities are already seeing this in New York, New Jersey especially. And so these are ways that we can handle that volume. So these are things to prepare from now. Again, changing the rounding model. If you have enough physicians to do it, separating out admitters and rounders, giving separate roles so everyone can be more efficient. And considering changing around the nocturnist model. So some of our nocturnists, for example, would want to extend their shift into a partial day shift and rounding on some of the patients during the daytime after their shift is over, or even switching the nocturnist to a day shift so they can round during that time while they're off potentially. Some facilities are even using a remote call center to offload the burden of cross-cover pager overnight. And as you can imagine, as the admissions start picking up at night, it makes perfect sense to have someone that could remotely take that cross-cover pager, whether it's a physician or APC at home or whatever, again, to offload the burden for the physician so they can concentrate on admissions. And lastly, increasing shift hours as needed. Some programs are having 8 or 9 hour shifts, for example, so increasing hours as the volume increases may make sense there. And working with your consultants. So some of us are getting hospitalist consults for very routine types of things. Of course, with COVID-19, a lot of elective procedures are getting canceled, so you may not get the ortho consult for an elective hip or knee because probably those procedures aren't happening right now. But still, there may be some opportunity to reduce the number of consultations. So work with the consultants to eliminate the lower risk consultations. For example, if you're consulted for hypertension and do the initial consult, and then the patient is stable after that, you can consider signing off and then being available as needed. And so having that conversation up front with the consultant so they're aware, and having that kind of shared agreement would be very helpful during this time. And secondly, returning the admitting responsibilities back to the appropriate specialist. So if the culture is at your facility that the hospitalists, for example, admit acute cholecystitis cases, this may be the time for the general surgeons to take those on their service and us to not necessarily be involved unless we're needed. And same with cardiology, same with ICU. It may not be needed for us to be involved on all of those cases. And so when the volume gets really high, this is the time to do that. Certainly when the volume starts going back down, then it makes sense for us to be back involved because co-management would be best, but not at the expense of having too high of a volume on the service. I'd also recommend working with your medical staff office to get expedited credentials process in place now. Now is the time to get everything prepared before the high volume starts. And even if you have an expedited credentials process in place, I know a lot of facilities are going through that process again and eliminating unnecessary barriers there. So how can we make it happen even faster? Because again, when the high volume does come, we will need to get physicians credentialed ASAP. And so how do we make that a more streamlined process? You can also consider asking other hospitalists and primary care physicians, internists in the community, et cetera, even post-acute physicians to join your team. As your volume continues to increase, you're going to need that help. And certainly with some of the outpatient practices closing, they'll have increased bandwidth to help. And in that same vein, having specialists even join the hospitalist team. I've heard many reports of nephrologists, cardiologists, et cetera, joining the hospitalist team. And even in some cases, specialists that may not be comfortable handling complex hospitalist cases are taking the sort of lower acuity cases just because that's what they need to do on an urgent basis to get the patient seen and properly cared for. And lastly, consider even enlisting APCs and other specialties. Again, as some of the elective outpatient heavy practices start to close because of COVID-19, this may be an opportunity to have APCs involved in your group as well, even if it's to help offload the burden of note writing and things like that. Any help when the volume is as high as it has been would be appreciated. And some of those facilities are already seeing 3 times the amount of patients that they normally would. So you can imagine that some of these tactics would be extremely helpful for those teams. And this slide talks about how to handle that high volume with a GME program. So some of you may work at facilities where there's a graduate medical education or residency program. And I would advise working with the residency program director in order to maximize the resident availability. So one thing we've done at Grand Strain was we've taken our residents off elective rotations where we could in order to not only protect them on the outpatient side so they're not getting unnecessarily exposed to COVID-19, but to increase inpatient bandwidth as well. When the surge does hit, they may be needed in the ICUs to help see more patients or on the inpatient side. And it would be a great learning opportunity for them to be involved in that as well. And some of those outpatient practices, again, are closing as a result of COVID-19. Consider also adding non-GME patients to the GME attending physician's daily workload, or even suspend the caps on the GME team. So as an example, if the GME team has a cap of 12 patients or 16 patients, whatever it is, that one attending physician typically supervises that number of patients. In this time during COVID-19, when the volume is very high, that physician may be able to see the patients independently or with the team, whatever works, but that might be another opportunity for help. And lastly, add GME physicians to the non-GME schedule as able. In some facilities, the teaching docs are separated completely from the non-teaching, but this would be an opportunity to get the help where they can. And I want to talk about this important topic, minimizing the risk of exposure, especially when it pertains to PPE. It's so important for us as physicians and APCs and anyone in the healthcare within the hospital to be utilizing proper PPE. And so know what the guidelines are, know what they say, know to protect yourself, and be also careful about donning and doffing of the PPE. It's not just enough to be wearing it appropriately. It's also important to be taking it on and off appropriately and know what the proper procedure is. There's potential high risk of exposure when taking it off as well. And certainly there are telemedicine opportunities. A lot of outpatient practices I know are already engaging in this. But even on the inpatient side, you can provide telemedicine coverage and minimize the number of physicians that are going into the room and things like that, which is the next point, limiting the persons that are entering the patient's room. And there's so many ways to do that. If, for example, a food tray is left outside of the room, rather than having dietary take it in as they normally would, they would keep it outside. And if I'm the physician that's going in to examine that patient, I'll happily take that tray in to minimize PPE and minimize exposure. And same goes for nursing things and things like that. There's also opportunity for a shared physical exam. So if I'm the hospital seeing the patient and I have, let's say, a cardiology consult and an ID consult, the three of us could get together and I could go in because I'm the hospitalist and I know what's going on with that patient, see the patient, do my exam, and then the cardiologist and ID doc could take my exam. They wouldn't be able to say that it's theirs, but they can list it in their HPI and also document clearly that they did not personally examine the patient. And this is another example, this picture I got from Mount Sinai. And these are IV pumps outside of the room. So I know some facilities are already doing this, but just with some extended tubing and, and some supplies there, they were able to keep all of the IV pumps outside of the room. So we all know all the times we go into a patient's room and those pumps are beeping. There's adjustments needed, something needs to be looked at, whatever. And so these nurses have been donning and doffing that PPE every time they had to go in because of a beeping IV pump until they did this, which is a genius idea. So they kept them outside and now they can adjust whatever they need to right away without using PPE and without getting exposed. And so that's just one example of something that can be done, but a really out-of-the-box idea. That's a great thought. And other things to do, I kind of put this in here because it's a hilarious photo from CDC there with facial hairstyles and such. But before work, I know a lot of us are already considering no jewelry, so no bracelets, no watches even, no dangly earrings, just minimizing the number of things that you'd have to sterilize when you get home that you also have to worry about properly covering with PPE. Same goes for long hair. Make sure to tie it back. Men should shave their facial hair. You can see on the chart there on the right what would be considered acceptable and not. And another great idea is to just put your cell phone in a Ziploc bag. How many times do we take out our cell phone during the day and take a look at it and all that stuff? And so that could be a potential source of contamination. And while at work, avoid touching surfaces if you can. So if you can touch a light switch or an elevator button or a door handle with your elbow or something else, it's much better to do so rather than touching that and then actually touching your face or something afterwards. I've seen a lot of physicians just taking the stairs over the elevator, knowing the elevator would be a closed-in space and potential exposure. Wiping your stethoscope and pager, that's the kind of thing we should have been doing all along, but there's never been a better opportunity and a better time to be doing it, definitely between every patient, but just in general, certainly before you take that home or you hand it off to your colleague. And a lot of physicians I know are bringing home food from home just to avoid going into the cafeteria where there's just a ton of things that they would be touching that everyone else has. And facility considerations. These are some basic things, but things everyone should definitely be doing. So make sure there's dedicated floors or units for COVID-19 patients and PUIs. Some facilities are already at a point where their entire facility is filled with them, so they're not dedicating them. In some parts of the country, in New York, for example, they have entire facilities that are designated as the COVID facility, and patients are getting transferred there for that reason. And within your hospitalist team, make sure that you're minimizing as best you can and keeping certain hospitalists that are designated to see those COVID-19 and PUI patients. And consider risk factors for severe illness by the COVID-19 as an exclusion criteria. So if you have older physicians in the group, pregnant, immunocompromised, whatever it is, consider having them out of that pool. Clarify the transfer process at your facility. Know if you're a facility that's been designated as receiving COVID-19 patients because you have the ability to handle them, or if you're the opposite. And know your elective procedures policy at your facility. The American College of Surgery put together a tiered system where they have the elective procedures in tier 1, and then the most urgent procedures as tier 3. Of course, those tier 3 are going to be the ones that they're going to be operated on regardless because the patient needs surgery immediately for, let's say, an acute abdomen. And then the elective ones at tier 1 are the screening colonoscopy and things like that. But there's a ton of gray area there. And so your facility may still be allowing some of those patients, those tier 1 or tier 2 procedures to occur, knowing that we just don't know when COVID-19 is going to be over with and when we can go back to all of the regular surgeries that we had previously. So if you can imagine, there's a AAA patient who knows they don't need surgery tonight, but they probably shouldn't be waiting another 6 weeks for the surgery to occur. So that type of surgery may still be happening. So as a hospitalist, we should really know what the policy is for that. And consider radiology restrictions, same type of thing. If a study is not absolutely needed, please don't order it. You know, if it's something that they need, then absolutely order it. But it's the same type of concept that if it's a COVID positive patient or even a PUI, we're potentially exposing everyone in the hospital as that patient gets transported, then down to the radiology unit, again, exposing people down there. So if it's needed, absolutely get it. It's the right thing. But if it's not needed, just something to consider. And another idea that some hospitals are already doing with the reduction in elective procedures, some of those ORs are being flipped to ICU rooms, and they could even be negative pressure rooms if needed, with the vents already there. So some workflow considerations. Think about even having a screening process in place. Absolutely every facility should have this, but I mention it because it shouldn't just be for the patients that are getting screened and asked those questions. Consider it happening also for every visitor that comes into the facility. The last thing that you would want is someone that had potentially a cough or even a fever that came to visit their loved one and then spread it around to others. And we have seen some transmission as a result of that type of thing. So it's a good idea to have some type of policy in place. And same goes for healthcare workers. So at my home facility, Grand Strand Medical Center, we've for several weeks now been doing temperature checks on everyone that enters the building, which I think is fantastic because it's a great way to make sure that everyone that's in the building is at least screened, and we know that we're protected on the inside as well as the patients. And the other things are hospitals call the patient room to conduct an interview through the phone when possible. So this way you can interview your patient, ask what's been going on, have that type of conversation outside of the room. It minimizes the time you're face-to-face with the patient, which is not ideal in the long run, but in the setting of COVID-19 will minimize exposure. That way you're only there in the room for exam or procedures. And again, as I mentioned, having one physician enter the room out of all the consultants on the case, and then the others can use the exam listed in the HPI. And one thing to just be aware of as this continues, again, some facilities are already at this point, but be prepared for critical care management. It may get to a point at your facility where you're called on to provide critical care as the hospitalist. And if it's not you, it could be anesthesia, it could be others on the team, but this might be something that you're not doing every single day, but it's a good idea to be prepared. I know SHM has critical care resources that are free to anyone to look at this time that are geared towards hospitalists for critical care management. So again, now would be the time to prepare for that. And I put this slide together for documentation opportunities, and this is some suggested wording. The first paragraph is really to ensure that the patient will be covered for services provided per recent acts of Congress. It's not just about relaying the information to each other so everyone on the healthcare team knows about the patient having COVID-19, but consider having some type of templated wording so that it's clear what this patient had. And you can read as an example, what I had there. And the second bullet is writing when you cannot do a full exam because of minimizing PPE or having a shared exam type of thing, as I mentioned. And you could say, for example, full physical exam could not be performed due to COVID-19 isolation protocols. And if you're doing something like telemedicine, whether it's over a Zoom session or FaceTime, these are some suggested physical exam findings that you can still use. Of course, nothing will replace being there physically and examining your patient one-on-one. But if you cannot do this safely, telemedicine, a limited exam, or whatever can be an option. And let's talk about communication. Ensure first that the positive COVID patients and even PUIs are being properly flagged on your EMR. The last thing that you would want is for you as the physician to identify that this is a high-risk COVID patient, but nobody else is aware, especially the nurse who continues to go back into that room multiple times in the next hour and all of that. And certainly for your physicians in the handoff process, when your colleague comes in to see the patient the next day, it should be very clear that this is a positive patient or a PUI. And I would also advocate for hospitals' involvement in the COVID-19 movement at your facility. We're, as hospitalists, involved in every department in the entire hospital, so it's so important for us to have a voice. And that includes with hospital policy. So if there's COVID-19 meetings happening, which I'm sure that there are, it's helpful to have our voice or someone that we're designating. So whether that's the chair of medicine at your facility or whatever. And make sure that there are timely and updated informational memos going out to everyone on the team. We all need to stay updated on what's happening, temperature checks at the door for visitors and things like that. We all need to know what's happening. And I know some facilities are already distributing a report regularly, sometimes to certain departments, sometimes to hospital leaders. Some of the facilities, like my home facility, Grand Strand, is giving this to every medical staff member every day, which I think has been so helpful. So they send, for example, the number of positive COVID-19 patients, as well as PUIs, and even what our PPE inventory looks like. I think it's really helpful for us to know what the status of the facility is so we can make decisions accordingly. And now I'm going to switch gears a little bit and talk about discharge planning. So one thing we need to consider, first of all, I want to say it's so wonderful that we're even talking about discharge planning for COVID-19 patients. Now we're at a point where we've successfully treated patients with COVID-19 and they're safe to go home. So we do want to make sure that they stay safe once they do leave to go back home. So consider getting a patient education document together so they know even what steps they should take when leaving the hospital. For example, they should be wearing a mask while in the car with their family member who's taking them home. They should wipe down the surfaces within the car so they don't get anyone else sick. They should be self-isolating, using a face mask for the duration of time accordingly, which I'll review on the next slide. And cleaning surfaces at home, making sure that keeping a clean environment to prevent further spread. They should still monitor their symptoms. So if they have worsening fever, shortness of breath, any of those symptoms that we know are associated with COVID-19, they should seek medical attention. And they should always be calling ahead before seeking further care where they can. So if they're calling their primary care physician for an appointment, they should make them know, make sure it's known that they were positive for COVID-19 or had suspected COVID-19, and that way the office can make arrangements accordingly. Physician consideration. So when is it safe for us to discharge patients home? Really, the patients can be discharged from the healthcare facility whenever clinically indicated. Don't wait for that COVID-19 test to come back. If they're safe to go home, absolutely get them home, but make sure that there's proper discharge documentation in place so they know how to self-isolate and how to take care of themselves at home, and have an avenue for them to still receive that COVID-19 test. I've heard of delays of over 7 days to get a COVID-19 result back. And so we certainly want to get the patients home as soon as they're stable rather than wait for those tests. And as far as discontinuing that home isolation, they should know that any patients or even healthcare providers that are going home, if you had symptoms, discontinue the isolation when all of the following occur. So in the last 3 days, you have not had a fever. That means off any fever reducing meds. And you also have not have had improvement in your cough or shortness of breath. And you've also had at least 7 days passed since your symptoms first appeared. So you should have all 3 of those items. And if you have all 3 of those items, you no longer have to have all that strict isolation. We should still be social distancing and doing all those things accordingly, but they don't have to have this strict face mask adherence within the home and things like that to prevent spread from to their family members. And if you did not have symptoms, you can't really go off of all those other criteria. So you can discontinue isolation when all of the following have occurred. So 7 days have passed since your date of first COVID test, or that you have no further illness. So lastly, I want to talk a little bit more about post-acute care. It's so important for us to continue that communication when a patient not only goes home, but also to a skilled nursing facility or a post-acute facility. So have resources on hand. Have something like a transfer form. Some facilities have this in place where it could be a shared agreement between the hospitalist team and the skilled nursing facility team, with basically criteria together that they would be comfortable discharging the patient to that facility. And the things we need to consider are, can that facility handle the patient, and will it result in a problem for the other residents of that facility? And including discharge instructions, that's one thing to make sure that they have as well. So the patient knows very clearly what to expect, but also the facility knows what they need to do or what occurred. And I'd also recommend, if at all possible, doing a template on the discharge summary, including things like, did the patient, were they suspected of having COVID-19? Did they get tested for it? What was the test result? Things like that. If you have it templated in, it would be very helpful for the skilled nursing facility directors. And considerations for the inpatient clinicians, for all of us to know, there are still some facilities out there, post-acute facilities, where the post-acute physicians and APCs are getting blocked from entering the facility. And that, as you can imagine, they're doing that to be ultra careful about what is being brought into the facilities. But just know that that's still existing. So that may be a barrier when you're trying to discharge patients to the facility. I'd advocate to coordinate meetings to streamline that transfer process, so that way there's good communication between the inpatient and post-acute. There's never been more of a need for that than now. And together, we really need to ensure that the patient can be cared for in that facility. And as I mentioned, that the safety of the other facility residents will not be compromised. And this is very important for us to know about. In media, I'm sure we've all heard about cases where, some homes have, nursing homes have resulted in a lot of cases. So we need to be ultra careful of that on the inpatient side. So I want to end on this note. The picture on the left is a picture of homemade masks that were made by community members in South Florida and then donated to the hospital. Of course, we want to be using PPE within the hospital if they have it, but for the facilities that don't have enough of it, it's so touching to know that there are community members who are helping and supporting our healthcare workers in any way that they can. And by the way, for those of you who don't know, JCAHO has approved the use of homemade masks, knowing that homemade masks are better than nothing, and we absolutely need to be protecting ourselves. And the picture all the way on the right says finding staff. This is the number of physicians, nurse practitioners, PAs, nurse anesthetists, respiratory therapists, RNs, LPNs that have volunteered to go to New York. A huge number there, as you can see, which is so heartwarming. And the picture in the middle is a picture within an airplane going to New York with all of these volunteers. Again, people across all departments. There's still social distancing within the plane, but they're up there and they're going into the front lines to help their colleagues that need their help and helping those communities that need them the most right now. And I thought that was just so touching that I needed to share that. And with that being said, I also need to recognize the team of talented individuals who I work with every day and have also contributed to the content you just heard. This is my team: Dr. Rohit Uppal, Dr. Suj Sundaraj, Tracy Gaglione, Kim Schneider, Suzanne Frank, and Melissa Armour. Every hospitalist and anyone listening has a team, whether it's nurses, spouses, MAs, therapists, case managers. We couldn't do what we do without them. So I encourage you all to work together, to support each other, and know that we will get through this. And with that, I'm going to stop and take some questions. I put my contact information there for anyone that has questions that we were unable to get to. I'm happy to answer them to the best of my ability. And I also have Dr. Rohit Uppal on the line to join me with answering these questions. Thank you.
Thank you so much, Ruby, for a really informative conversation this afternoon. I do want to remind folks, if you do have a question for Ruby and Dr. Rohit Uppal, please type those into the question box and we will get to as many questions as we can. While we're waiting for people to type in questions, Ruby, I was wondering if you could talk more a little bit about conversations with post-acute providers, you know, even if it's just experiences that you've had, you know, what are some strategies in terms of navigating some of those barriers that you mentioned and challenges in discharging patients to the post-acute space?
I would say one of the biggest barriers that I'm seeing is a lack of communication back and forth. So what I may think is acceptable being an inpatient hospitalist physician may be very different than what the post-acute director feels that they can handle at that facility. And also what one facility can handle can vary, you know, amongst the other. So, you know, I can't expect one facility to be able to handle everything that the next one does. This whole situation is so different than what we're used to. And so some are pretty well prepared and others are lacking PPE, staffing, and all that kind of stuff. So they're looking out for the best interest of the patients that they already have at their facility. But we also need to get those patients home, not only to free up the beds for other people that really need them, but also to minimize exposure within the hospital. So there's got to be better communication in some of those cases to ensure that the needs of the patient will be met at those facilities, but the other patients will not be unnecessarily exposed either.
Great, thank you. At this time, we don't have any questions in the question box. I don't know if you or Rohit have any final comments you'd like to make. Oh, looks like we just got a question. How do you manage the hospitalist shortage when you have just a few to see COVID and non-COVID cases? In the case, the same doctor must see both COVID and non-COVID patients. How do you sort of manage that when you have a staffing shortage that means you have to have that kind of cross coverage?
I'd say it should be handled the same as when you have, a MRSA or a VRE patient requiring, all of the gowning up and everything. So using the precautions where you can, but then, seeing the patients in a still a protected way and making sure it's not transmitted to the others. But if that's the case where you have, you don't have the ability to divide it up, then that's the next best way to handle it, where you're just, being ultra careful about gowning up and being protected. Rohit, did you want to add anything to that?
I'm not sure I understand the question exactly. Is it referring to the fact that one of our recommendations is to have dedicated teams or dedicated units?
I think that might be it, where if you don't have the ability to have dedicated teams, and so you have to have the same physician seeing both COVID positive or COVID positive and PUI and non-COVID patients.
Yeah, so I think if you're in a facility where you have adequate staffing to do it and the caseload is relatively low, the dedicated unit and dedicated staffing is very effective. But we have found that once you are in that kind of low volume sporadic phase, that doesn't last very long. And once that volume increases, you can't sustain that model. So I wouldn't recommend people relentlessly try to stick with that model. You just have to know when it's no longer sustainable, and then you treat them like any other patient. Everyone on the schedule will take some of those patients.
Great. Another question came in around discharge planning and barriers to discharge home if, for example, patients and families are not wanting to go home until test results or until no longer contagious. Particularly, if the patient is going home with family members or other folks who in the home who maybe are at high risk. Do you have any strategies or thoughts on discharging to home when the patient may or the family maybe is not wanting to go home?
Yeah, that's a really great question. And I would say in some of those situations with proper education of how that patient can be safe, self-isolating at home, that can still happen. Certainly, although it's not exactly the same thing, but even physicians that are working and coming home are still in some cases, quarantining or for whatever reason because of exposure. And so that is happening to some degree. There's just a lot of precautions that need to be taken once the patient does return home to make sure they're quarantining themselves at home or whatever so that they don't infect their loved one. I think it's absolutely possible, but it requires a lot of education. And it still will, of course, we all know, depend on the comfort level of the patient we're trying to discharge. And if they don't feel comfortable until that point is met, that's a tough argument to have. But that would be my solution, is to make sure that they have that education about how to properly prevent spread at home.
Have you ever had?
I agree completely. Sorry.
Okay.
Sorry. I just had one other comment to make. I think it would be natural for anyone who was COVID positive to fear what that might mean for their family. So one of the things we developed is education, both for the patient and the family member. And I think it's important that they're educated, and hopefully that will create a greater sense of willingness to return home. The other thing I'll say is, if you're in an area of cluster or surge, throughput is always important, but under those circumstances, throughput is mandatory. So you get into a situation where you're already rationing healthcare resources, and if someone is clinically ready to go, you don't have the same leeway you might have under normal circumstances to take a day or two to maybe convince them. And so unfortunately, societal and community welfare trumps that individual patient's concerns.
There's a question about telemedicine, and I'm not sure if the questioner wants to clarify. The question is, are there telemedicine hospital opportunities that hospitalist opportunities that one can look into. So I'm not sure if that's strategies for telemedicine to bring into a hospital, or if that's for hospitalists who want to get involved in telemedicine more broadly.
Gotcha. Well,
Ruby, I can take this one.
Oh, yeah.
Oh,
please
sorry.
do. Sure. No, that's okay. Go ahead.
So first of all, I think we've all seen that telemedicine has taken some huge strides in this time of COVID pandemic. A lot of that has been on the outpatient side. We have expected, and we still expect, I think, a lot of interest on the inpatient side, and some of the relaxation of some of the restrictions around HIPAA and privacy concerns helps make that much easier. Really facilitates it. There are obviously platforms for tele-hospitalist services already in existence, organizations like Eagle Telemedicine. But now, we have a telemedicine process just using Zoom, and that's something that you can undertake with 24 hours, 36 hours of preparation time. So what I haven't seen yet is hospitals who are under duress say, we're going to now allow the use of telemedicine. So there's still, I think, a lot of pushback at the hospital level, and we'll see if the severity of this pandemic, moves the needle on the inpatient setting like it has in the outpatient setting.
Great, thank you. And then just a clarifying question about the first question. So in their practice, they're considering shifting doctors from the hospitalist team every 2 weeks to attend only the COVID area. Do you think that sounds like a reasonable approach?
So I do, and I think it depends on the volume of patients. Again, we have had many practices that started out with those intentions, but then again, as the volume of patients and PUIs increases, it just doesn't, it's not sustainable at some point. But as long as you can maintain that based on your volumes, I think it makes a lot of sense.
That's all the questions that we have. So I don't know if Ruby, you or Rohit have any kind of closing thoughts or comments for anyone?
Rohit, did you want to give any comments?
Well, I guess, I'm guessing many of the attendees are hospitalists, so I just want to thank all of our hospitalists and hospitalist leaders. The word I hear most often used in this pandemic is unprecedented, and I hear that word from people who have been practicing for decades. These are really extraordinary times, and it's been very impressive to see people stepping up with courage and selflessness. And Ruby shared that slide of volunteers who are willing to run into the fire to help. I've been using this word to describe our clinicians. You really are superheroes. So thank you for everything you're doing.